So a little bit about why RVUs matter. Go here. All right. So this is an excerpt from a CMS schedule from the Center for Medicare and Medicaid Services. This is 2025 National Physician Fee Schedule, and it is a very small section of a very large spreadsheet. And for anyone who attended our session a few months ago on insurance contracting, you'll have seen this part. And for some of you, this may be a little bit of a review. This is to basically show you the breakout between RVUs. So the relative value unit for any particular CPT code is shown here in its component parts and pieces. So each one, and we've highlighted the 99214, that's a code that we love to see clinicians using. And that one shows that work RVUs portion of that is 1.92. That's the value that CMS has subscribed to a 99214 for 2025. We take the work RVU, which many of you may use in your physician and clinician compensation systems, and we add to that the next column there is the non-facility practice expense RVU. So that is CMS's attempt to say, first and foremost, for the work RVU, here's a reflection of the clinician's energy and effort and expertise that had to go into providing that service. That second column is the practice expense. And so that's CMS trying to ascribe a value to how much practice resource does this take to deliver the service. And then that third component there, the malpractice RVU, is the piece that really kind of tries to define how much risk there is associated with providing the service. So with office-based services like this, we will see very low malpractice, and we will also see very low practice facility practice expense RVUs. So the juxtaposition would be if you were to look at a surgical code for, say, a neurosurgery or OBGYN, you would see a practice expense RVU that would be quite a bit higher, as well as the malpractice RVU would be quite a bit higher as well. That's how the CMS uses this as a relative value, and we'll talk a little bit more. But when we add up all three of those components, that gets us to our non-facility total. So in 2025, with 99214, when we add up all those components, we come out to a non-facility total of 3.87, and that is then the total RVU. It's important to have that distinction. Non-facility means that you are billing from a clinic setting, not an ambulatory surgery center or a hospital. So that's the anatomy and physiology of the RVU itself, how all those component parts and pieces get added up. On our next slide here, we have a little bit more detail about how those multiply. And I apologize, there's a little bit of a lag with the slides. Let's see if I can get that to go forward. Debbie, I may need your help forwarding the slides. All right. Okay, perfect. So this is a listing, and we've made this even a little bit smaller for you to focus in on the office-based codes. This is where we see quite a bit more opportunity for practices in the office-based visits. So as you can see here, finishing the math, the 99214 that we've just added up is that 3.87 RVUs for 2025. And within your practice management system, it is multiplying that 3.87 times a conversion factor, and that is what creates your gross charge. So we see that 3.87, and in this case, the clinic had a conversion factor of $90 per RVU. So that generates a charge of $348.30. That's what goes on your insurance claim, and that's what shows up in your billing system as gross charges. The last thing I want to say about this slide is to just have everyone pause for a moment and focus on the difference between the values of those three lines. So we have 99213, 214, and 215. And we're going to talk a minute about coding and which code you're selecting. And all of this is just, again, to kind of set the table and build the case for if you are rendering a 99214 level of service, but only charging and coding 13, you can see the difference there that makes financially. So this is what we want to help you recapture. I always want to pause at this point and take a slight detour. Now that we understand the math and the things that are going on in the purple boxes up top there, what we just talked through, that total RVU, where we added up all the pieces, times the conversion factor inside of your charge master, it gets you kind of what I call your retail price, right? That's your gross charge. That's what goes out on the claim. And then the payment from the insurer and the patient, less the contractual adjustments, is the cash that actually comes back into your practice. And we have the math down below is your Medicare, Medicaid, and commercial rates. And that is just to show the difference between the various plans. The Medicare for 2025 is paying $32.35 per RVU this year's. The 99214 will pay you 3.87 RVUs times the $32.35, and that gives you your traditional Medicare allowable is $125.20. So that's what you can expect to be paid for that 99214 when you see a Medicare patient. For this slide, we pulled the open card Medicaid rate. I believe this one is for Oregon or Washington, but they're similar around the country. And so you can see there, Medicaid is paying somewhere in the high $20 per RVU. So that same visit, again, your clinic can expect to be paid $110.30. And then your commercial contracts, so this will be your Aetna, Cigna, et cetera, Blue Cross Blue Shield, probably somewhere in the neighborhood of $50 to $60, maybe $70 per RVU, depending on the size of your group and your geography and your negotiating clout and whatnot. But assuming roughly $60, you can see that visit, same 99214 visit, will pay you $232.20. So this is the point in the presentation where I always stop and say, all patients are created equal, all payers are not. So this is where if you hear administrative folks or finance folks talking about payer mix, this is why we tend to get a little bit excited about payer mix. The excellent question to pause and ask yourself here is right at the bottom of the slide there, and that is, what is your cost per RVU? So that is an excellent piece of data to have. If you have a question about how to calculate that, it's fairly straightforward. You want to perhaps look at an entire year, so potentially you could look at 2024. Look at all of your expenses to operate your medical group for the year. Deduct any expenses that are for clinicians, so physician and clinician salaries, etc. You'll want to back those out. And then you'll take that adjusted cost number and divide by the number of RVUs that you rendered throughout the year. And that should be the number of total RVUs, not work RVUs. Some systems will split them out. So that's would be the way to calculate your cost per RVU. Most groups wind up somewhere in the $40 per RVU range is the cost before they pay the owners and the clinicians. So that's a good number to know, especially if you're negotiating contracts. But you can see if your cost per RVU is somewhere around $40, when you see a Medicare patient, you get paid $32.35 for an RVU. So that's a loss leader. Same with Medicaid. So that's why payer mix becomes important. We need to have enough commercially paid patients in the practice in order to create enough margin so that the physicians and clinicians can get paid. So that's a little detour I like to take, but we like to set the table there. And my encouragement, if we have administrators and managers on the line, if your physicians don't understand how these numbers break down, this is a great slide to share with them, perhaps at an upcoming physician meeting. I frequently find, and Dr. Hirsch, Ann and I are both faculty for our physician leadership project, and we frequently find mid and even late career physicians who don't really understand these building blocks, largely because we don't teach it in medical school. And so there's really not an opportunity for them to pick up